Hi, I'm Dr. Sharon Adler from the California Prevention Training Center, and I'm going to be talking to you about ocular syphilis and emphasizing why ocular syphilis is so important for all providers to be aware of. If you're a primary care provider, working in an ST clinic, or if you're an ophthalmologist, everyone should be keeping an eye out for syphilis. First, I want to start by sharing some data from the California Department of Public Health. This is data from the years 1996 to 2014, looking at our early cases of syphilis. And as you can see here, our cases among men have been on the rise since about the year 2000. And we have data that demonstrates that most of these men are men who have sex with men. And so that is where the vast majority of our epidemic is within California. Now, this data is consistent with our national data. So this slide here from the CDC looks at national data from 33 areas nationally for the years 2007 to 2013, looking at primary and secondary syphilis cases. And again here, highlighted in red, we can see that the vast majority of our cases are among men who have sex with men. So that is where we're seeing syphilis nationally. Very importantly, we also have information in terms of syphilis and HIV, and we have data nationally that demonstrates that a good proportion, anywhere between 50 to 70% of our syphilis cases for primary and secondary, are co-infected with HIV. And why this is so important is the natural history of syphilis infection in someone who's got HIV disease is going to be a little bit different than the natural history in someone who doesn't have HIV disease. And that person may be more likely to have serious sequelae, such as ocular syphilis or neurosyphilis. So let's review now the natural history of syphilis. This slide shows you the stages of syphilis. Syphilis, untreated, will pass from primary to secondary, then to a period of latency, and then a small proportion of people, about 30%, will go on and have tertiary complications. So this demonstrates that syphilis is a disease that has periods of active disease manifested by clinical manifestations, primary, secondary, and tertiary, and also disease that has periods of latent disease. And in latency, the only way to make a diagnosis of syphilis would be by doing a serologic blood test. But what I really want to highlight is down here in the yellow on the slide is that ocular syphilis and neurosyphilis can occur at any stage of syphilis. And CDC has been following cases of ocular syphilis, and these are being reported in many patients who have primary infection and secondary infection. So early on in their syphilis course of disease, they're being diagnosed with ocular manifestations. And it may be that their ocular manifestations are the presenting manifestation of their syphilis disease. So back in April of 2015, the CDC came out with a clinical advisory because they were seeing more cases of ocular syphilis, and there were two large cities in the United States, Seattle and San Francisco, which suddenly had 12 cases of ocular syphilis, which is something that many providers had not seen for a while. And so CDC has been following this, and what they found in the past 2 years, from 20 states, they have seen 200 cases of ocular syphilis. The vast majority of these have been among HIV-infected men who have sex with men. A few have been among heterosexual men and women who are HIV negative or HIV positive. But very importantly, many of these patients have been left with serious sequelae, including blindness in a few of them. And there have also been diagnostic delays because as a patient who's being diagnosed with an STD, that patient may not be aware to talk to their provider about ocular manifestations. And so it's upon us as clinical providers to make the connection and be aware that syphilis can manifest with ocular symptoms. The other thing that came out in this clinical advisory was that at this point it's really not known if there is a particular strain of Treponema pallidum. So Treponema pallidum is the bacteria that causes syphilis. Is there a strain of Treponema pallidum that is ocular tropic? That is not known, but there is precedent for this. There are strains of Treponema pallidum that are neurotropic, and we know this. And so the CDC is trying to investigate to see if the reason that we're seeing more cases of ocular syphilis, is it because we're just seeing lots of syphilis and so we're seeing more ocular syphilis, or is there a specific strain that likes to go that manifest with ocular disease? So let's talk about ocular syphilis and what the symptoms are in patients. And they are a whole host of symptoms. So patients may present, as in this picture, with redness and irritation. They may present with eye pain. They may present with floaters, flashing lights, or changes in their vision. And actual blindness may be a presenting manifestation of ocular syphilis. So a clinical provider needs to query their patient about these ocular symptoms because the patient may not reveal those if those are not asked of them in terms of their medical history. In terms of ophthalmologic manifestations, syphilis has always been called the great masquerader. It can mimic many other conditions. And in terms of its ophthalmologic manifestations, there is not one specific manifestation that is pathognomonic for ocular syphilis. There's a whole host of them. And in the 200 cases that the CDC recently reported, many of these cases presented with ocular manifestations as uveitis, bilateral uveitis, posterior uveitis, anterior uveitis, and panuveitis. But there's a whole host of other possible manifestations ranging from conjunctivitis, scleritis, episcleritis, keratitis, chorioretinitis to vasculitis. And so an ophthalmologist needs to be aware that syphilis is a possible etiology for all these manifestations. Now I'm going to move on and talk about a case. And this case really demonstrates some important points relating to ocular syphilis. And so the case patient is a male who's got male partners, and he's 31 years of age, and he presents to his provider because he's got a new rash. This rash is symmetric. It's on his trunk. It's a macular configuration, and he also has a rash on his palms. And I know in my medical school training, I learned that if you see a rash on the palms, you got to be thinking about syphilis. And so this provider is definitely thinking about syphilis. In addition, the patient has other risks for syphilis. He's a male who's got male partners, and he has methamphetamine use, which has been linked to syphilis as well. Interesting, this patient also has some visual complaints. He complains of 1 month of blurry vision, and he has general malaise. He just does not feel well at all. So this provider is thinking about syphilis. He sends off an RPR, which turns out to be negative. He also sends off testing for HIV, and it turns out this is acute HIV. This patient has a rapid HIV test that's positive. And he's referred to an ophthalmologist, and the ophthalmologist makes a diagnosis of retinitis. But what's going on here? What might actually bring this case together? What might explain this patient's rash and ocular manifestations? Turns out what explains all of this is that it actually is syphilis, and that the RPR test was a false negative RPR. So all providers need to be aware of something called the Prozone. It's a false negative. It can occur, and it's somewhat more likely to occur in secondary syphilis as well as in HIV-infected patients. And in this case, when the provider repeated the RPR or asked the lab to dilute the serum, the repeat RPR was actually very reactive, 1 to 1024. With the treponemal specific test that was positive as well. So we can link the rash to the ocular symptoms, and so the retinitis is a manifestation of that patient's ocular syphilis, and the rash is secondary syphilis. In addition, what's recommended in any patient who's diagnosed with ocular syphilis is that they get a lumbar puncture to make sure that they don't have neurosyphilis as well. And in this case, this patient does have neurosyphilis. His CSF is positive of the VDRL of 1 to 16, and he has pleocytosis, so he's got elevated white blood cells. So he's got ocular syphilis, neurosyphilis, and secondary syphilis. So now I want to just briefly talk about the Prozone phenomenon. As I said, it's a rare phenomenon, but all providers need to be aware of it, particularly because it may occur somewhat more commonly in HIV-infected patients and neurosyphilis. So it's a false negative RPR. This graphic demonstrates that what you're looking for in the RPR test is the complexes that are forming. So it's an antigen-antibody complex that forms, and that causes clumping of the chromogen. But you can imagine if there's too much antibody around, if that patient's producing so much antibody, that can overwhelm the antibody-antigen reaction, and that is what took place in our case patient. So it's a false negative, but you can ask the laboratorian to dilute the serum and look for the Prozone. As I mentioned, this occurs more commonly in HIV positive and neurosyphilis. So providers need to be aware of the Prozone when they're thinking about ocular syphilis. So some other teaching points in ocular syphilis. Be aware of it and recognize that if you delay diagnosis, this may lead to more serious sequelae in your patient. It has led to blindness in some patients in the cases in Seattle. So patients who are diagnosed with syphilis, they need to be queried about any visual complaints. You need to ask them, are they having any changes in their vision? Are they seeing any floaters, any flashing lights? If they respond that they're having visual complaints, they need to have an immediate ophthalmologic evaluation. All patients with syphilis also need a neurologic exam, and that neurologic exam should include an evaluation of their cranial nerves. Similarly, ophthalmologists who are diagnosing patients with a variety of ophthalmologic manifestations need to consider syphilis as a possible etiology, particularly if you've got a patient who's HIV positive, particularly if you have a patient who's a male who's got male partners. But then that means that the ophthalmologist needs to get a little history and ask about risk factors for syphilis in their patients if they have possible manifestations that could be consistent with syphilis. When they're ordering syphilis serologies, they need to order both a treponemal and a non-treponemal test. And that's because you can have this false negative non-treponemal test called the Prozone. So how should patients with syphilis be managed? All patients with syphilis and ocular complaints, or patients who are diagnosed with ocular syphilis, need to have a lumbar puncture. It's important that providers realize that a negative lumbar puncture does not rule out ocular syphilis. You can have a diagnosis of ocular syphilis and have a completely normal CSF. No matter what, if you've got ocular syphilis, you need to be treated with a regimen that covers neurosyphilis. It's a 10 to 14 day treatment, IV therapy. All patients who have syphilis and who have ocular syphilis need to have an HIV test if their HIV status is not known. And then all patients with syphilis, and particularly with ocular syphilis and neurosyphilis, your local health department wants to be alerted about these patients, and you should report them to your local health department within 1 working day. So here is the regimen for neurosyphilis and for ocular syphilis. So patients with ocular syphilis get treated with 10 to 14 days of aqueous crystalline penicillin G at 18 to 24 milliunits IV daily, which is usually administered as 3 to 4 milliunits IV Q4 hours for 10 to 14 days. Also, at the completion of this IV therapy, it is given a consider recommendation in the treatment guidelines that these patients get benzathine penicillin G at 2.4 million units IM once per week for up to 3 weeks. And that's so that the treatment that they receive is of comparable duration as if they were treated for late latent syphilis. So finally, I want to thank you for your time and your interest in ocular syphilis and let you know that there are a host of syphilis resources available to you, whether it be from the CDC, the California Prevention Training Center, the California Department of Public Health, or the National Network of STD HIV Prevention Training Centers. Thank you so much.